Hi all, I am Revati Kadirvel from Medical and Surgical Nursing Department, SNS College of Nursing. Today we are going to discuss about cholecystitis. In this video, we are going to review the surgical anatomy and physiology, cholecystitis definition, types of cholecystitis, pathogenesis of cholecystitis, clinical features of cholecystitis and differential diagnosis of cholecystitis, investigations used for cholecystitis, collaborative management used for cholecystitis. So anatomy of gallbladder shape: pure and globular shaped organ, size 8 to 12 cm long, location right hypochondrium or inferior surface of the liver in fossa, parts fundus, dilated portions of GB attached to undersurface of liver. Neck: the narrow angulated and distal portion of neck called as hot man's pouch, also called as infundibulum of GB. So anatomy of gallbladder: pure or globular shaped organ. So duct which is present in gallbladder. GB drains into common bile duct, CBD through the cystic duct. Lumen is 1 to 3 mm in diameter. Valve of Heister is produced as functional valve due to the contraction of GB. Caller's triangle, it's important landmark to identify cystic duct and cystic artery during cholecystectomy. Laterally cystic duct and GB. Medially common hepatic duct above inferior surface of right lobe of liver. So ducts of gallbladder: right and left hepatic duct. These are originating from the liver. Common hepatic duct. The right and left hepatic duct in union forms of CHD. About 3 cm receives cystic duct and forms CBD. Common bile duct, about 8 cm in length, has 4 parts: supraduodenal, retroduodenal, infraduodenal, intraduodenal. Combines with pancreatic duct from duct to form ampulla of water. So this is the diagrammatic representation. So physiology: functions of gallbladder is reservoir for bile. Concentration of duct mucus secretions is happening in gallbladder. Bile secreted from hepatocytes. Normal pH level of bile is greater than 7.0. Secretion of to 1 liter per day. So definition: the inflammatory condition of gallbladder is called as cholecystitis. Acute cholecystitis: acute bacterial inflammation of gallbladder with or without stone. Types: calculosis, acalculosis, acute emphysematous cholecystitis. The calculosis, it is obstructive cholecystitis due to gallstones, having the most common variety in which around 90% of people having gallstones suffers. Acalculosis, it is the non-obstructive type which is common in person suffering from major illness like severe sepsis, burns, DM, that is diabetes mellitus, dehydration and multiple injury, etc. Acute emphysematous cholecystitis, it is a rare form of acute cholecystitis where gallbladder wall necrosis causes gas formation in the lumen or wall. Causes: majority of cases of calculous cholecystitis are due to the organisms such as E. coli, streptococci, salmonella, klebsiella, etc. In typhoid fever, around second week can cause typhoid cholecystitis. Even clostridial infection presents with toxemia. Pathophysiology: stone, outlet obstructions, that is leading to stasis, that is going to bacterial proliferation. Then stone is extracted to mucosal erosion, destructions of cell by toxic bile ducts, that is leads to bacterial proliferation. So those things leads to necrosis and perforation. So clinical features of cholecystitis is 4 Fs are seen: fatty, fertile, female, 40 or 50. Represents as a colicky pain and more prolonged due to inflammation, nausea and vomiting, initially lower grade fever. feeling of fullness, abdominal distension, fat intolerance, anorexia, nausea and vomiting, jaundice may occur, fever and leukocytosis. So Murphy sign. Keep the fingers in right hypochondrium and told to take deep breath. At the height of inspiration, there is a sudden catch of breath. It is due to inflamed gallbladder coming in contact with abdominal wall. This is called Murphy's sign positive. Bose sign. Feel of hyperesthesia between 9th and 11th ribs posteriorly. Rigidity and girding of upper abdominal valve. Presence of vagus mass of gallbladder, omentum, exudate. So diagnostic studies for cholecystitis is total WBC count is always raised, blood and urine analysis, plain X-ray to rule out gallstones, gallbladder calcification. Ultrasonography success rate is more than 95% to predict calculus posterior acoustic shadow, acalculus inflamed and thickened organs. So treatment, first is conservative treatment, that is medical management, admission, aspiration of HCl with Ryle's tube, antispasmodics, injection morphine 8 to 10 mg IM along with injection atropine 0.6 mg to relieve spasm, antibiotics. Patient is kept NBM for 2 to 3 days. During this period IV fluids are given. So management, surgical management is yearly cholecystectomy, emergency cystostomy and prophylactic cholecystectomy. Thank you.